Hi and welcome everyone here. I can see that people are still joining to us, so we will wait a couple of minutes before we start. And before we start the slides and the introduction, welcome everyone here. Today's topic is low back pain. And we are going to wait just a couple of moments here. I still can see that the participants number is rising here. It's wonderful that so many people joined to us today. Yes, and feel free to use the chat function. Feel free to ask questions and jump in. Hopefully, in the end of this webinar, we will have at least 15 minutes for questions and answers. And as I can see that almost 50 participants are here already. So welcome everyone here. I will have to jump in and out a little bit with our presentation because of Zoom and the voice and the videos, what we want to share with you today. Welcome everyone here. I am Zsófia Nagy. I am research associate for the European Pain Federation who organized this webinar today. Today's topic is low back pain, as I mentioned it, comparing approaches. And oh, I hope I can move forward. Yes, and I would love to give the floor for our today's speakers. Indre and Daniele are here with us today. Welcome, and thank you for your time to host this webinar. Please introduce yourself, and I will give you the word, Daniele, and move forward.
Hi, my name is Indre Bilevciute-Junger, and I am Associated Professor in Rehabilitation Medicine at Karolinska Institute. I'm also clinically working very much and seeing pain patients. I am a senior consultant at the Pain Rehabilitation Unit at Department of Rehabilitation Medicine at Danderyd University Hospital here in Stockholm, Sweden. I'm also a vice president of the Lithuanian Pain Society and also a chair of Educational Committee of EFIC since 2023. Thank you.
Hi everyone, my name is Daniele Battelli. I am an anesthesiology by extraction, and I work as the chief of the pain medicine and palliative care unit in San Marino Hospital in San Marino Republic. I also am involved in EFIC as an executive board delegate and as the chief of the EDPM examination as a exam director since 2023. Thank you everyone for being here in this webinar today. The European Pain Federation, EFIC, is an European scientific society that involves all the ISP national chapters. In Europe, we are made up of 40 European pain associations that puts together more than 20,000 healthcare professionals, physicians, basic researcher, nurses, physiotherapists, psychologists, and any other healthcare professional that it's involved and interested in the study and in the clinical aspects of acute and chronic pain. Our association brings on many educational initiatives for healthcare professionals, both for physicians as well for physiotherapists, nurses, and psychologists, like the biennial congress, like these webinars, the EFIC Academy that you can find and subscribe to in the EFIC website, and as well as diplomas for physicians, for physiotherapists, and since 2024 also for nurses. You will find everything about the EFIC diplomas in the EFIC website if you are interested in. So today our webinar is focused on 2 of the 7 clinical case videos that have been produced by our group in 2024. You can find the EFIC clinical case videos that are interactive videos exploring different chronic pain conditions, putting into scene a real-world scenario of a clinical evaluation and a clinical interview and a clinical examination about chronic pain conditions that you can find into the EFIC Academy. The 2 videos that will be today evaluated and in-depth analyzed by me and Indre will be the 2 videos that you can find on non-specific low back pain and on lumbar face joint syndrome. Those are 2 clinically very relevant, very frequent, and almost always overlapping chronic pain conditions. So we decided to build a webinar on them just to have a confrontation about those different aspects that may involve both the physical medicine and rehabilitation physicians, as well as anesthesiologists and pain physicians more involved into interventional aspects of chronic pain patients' treatment. So we will put together the clinical specific aspects of those 2 clinical syndromes, analyze them, and more important, be extremely open to all your questions, all your confrontations about those 2 topics. Remember that you can subscribe to the EFIC Academy with a link that you find also in the slide. In the Academy, you will find a lot of useful educational material, also to prepare for our examinations, the ADPM, the ADPP, and the DPN, and as well as those clinical videos that you will find and you may all maybe already seen in the links that have been provided to you in the past days about non-specific low back pain as well as lumbar face joint syndrome. The agenda for today will start with Indre Bilevičiūtė-Ljungar talking about the non-specific low back pain, analyzing the objective and clinical examination, the clinical findings, and the role of imaging and of interventions, therapeutic approaches, both from a physical as well as a pharmacological and interventional point of view for those clinical syndrome, low back pain, and face joint syndrome, and then a final confrontation about the gray zones of these overlapping syndromes and the integration, the multidisciplinary integration and the multimodal treatment for those chronic pain conditions between different healthcare specialties and many different healthcare professionals.
Thank you, Daniela, for this very nice introduction. And we can start to talk about non-specific low back pain. Yeah, it's a very interesting definition. In my world, it means that can I picture? In my world, it means that it's not inflammatory pain that could be treated with drugs, so it can be of rheumatological origin, and it's not neuropathic pain. It's something that we usually cannot find real explanation. And during longer time, if it stays and not treated, it can develop to so-called nociplastic low back pain. And as clinicians, we always starting to take good history, pain history, what we call pain anamnesis, just trying to understand the the main clues which can lead us to investigation and to our hypothesis, what kind of pain these patients suffer. In not so much complicated cases, maybe it's easier. For example, if we have quite new developed pain, it's not so chronic, not many years, maybe some months, more than 3 months, and we can address other issues as of course, we need to screen for red flag, for yellow flags, and if we can address, for example, some stress impact or some other issues, for example, as sleep difficulties, and if we can already listen if patient tried some medication, usually this first pharmacological treatment is bought by patient and tried by him or herself. It's usually non-steroid inflammatory drugs or paracetamol, which maybe help at the beginning and then is not helping. Also very important to listen and to ask about signs of some neurological involvement, is like muscle weakness, which is not so much pain related, or numbing or other neurological subjective signs, which can give us a clue if there is some idea to test the neurological examination, sensomotor aberrations. When cases develop a little bit longer, usually we find some kind of sleep difficulties, which are insomnia, awakenings during nighttime because of pain. That gives us some kind of idea that we have more than pain. We have other systems involved, and sleep, of course, is nervous system involved, and then we can look for other signs which do not help patient to restore and do exercises, and maybe in time we started to get anxious and maybe depressed. So this like a whole picture, not just only focusing on pain, but also on other pain-related symptoms. We can, if patient has already developed nociplastic pain, we can have other pain syndromes in even low back pain, but also other symptoms such, for example, chronic pelvic pain syndrome or irritable bowel disorder, but these are not directly correlated. Also, it's very important, I always have pain drawing with my patient and discuss and look at the parts indicated by patient which are painful, and asking about radiation and when the pain starts and which is the worst pain in the pain drawing. So that can give me a clue how to go with my clinical investigation. Patients with low back pain usually have stiffness in the morning. They have difficulties with the range of motion in the back, so that we also can test during clinical investigation. Also, such tests as balance tests, which are quite simple to do, but they give us a lot of information. Romberg test for balance, or standing on one leg, and of course other tests when we do clinical investigation, that we can think about the possible involvement of neurological spine structures or peripheral nerve structures. For non-specific low back pain, usually palpation of muscles by itself is painful in that affected parts which are indicated in pain drawing, so we can see the clinical findings together with what patient is talking, what we are asking, listening, and seeing and observing patient already, maybe on their way to the our investigating room, for example, the walk. Okay, maybe we can take the next slide and look at a very short video presentation. This is very short, and the video, maybe it's too long, it never will work in the clinical practice, but it's like a case what you should think about when you investigate the patient. this video, which is on the Academy platform. Now we will look only the very short video.
Yes, I will share the video right now, and then I will be muted just to let you know everyone. I hope you will hear the voice as well. Please give any feedback in the chat if you cannot hear the video.
Hi, George.
Hi.
My name is Indra and I am a pain doctor. We got a referral from your family doctor saying that you are a 40 years old person who has low back pains.
I have pain in my back, sort of lower part of it, kind of around the back, like a band of pain. My legs, it's not all the time.
Is this pain in the lower back continuous?
Yeah, it doesn't really stop. It's all through the day, and I feel it at night as well. I always feel the back. I don't always feel the pain in my thighs and my buttocks. I feel like it's difficult to do certain movements because of it. I can't remember the last time I had a good night's sleep.
From your story, I suspect that you have non-specific low back pain. It means that you do not have any diseases which can explain your pain. We need to exclude that you do not have some nerves engaged giving these symptoms. Please follow me to the bench. Okay, let's test your balance. Put your feet in a line, if you can put your feet like that. Do you think we can try that you close your eyes? Okay, no, it's okay. So I was starting with squeezing your muscles here in the upper part of the spine. Especially here. You feel pain?
Yeah.
I'm not squeezing hard. I squeeze all the way because you have pain here as well. Is it painful here?
A little bit.
Now the next test is that I will raise your leg. It will be me, not you. You will tell me when you starting feel pain and where, okay? And I'm doing it very gently. So, where do you feel your pain?
It's like stiff in my legs.
Okay, maybe we can move on the next pain syndrome. Please, Daniel.
Yeah. Facet joint syndrome is frequently overlapping in a patient with non-specific chronic low back pain. To remember that non-specific low back pain is a diagnosis of exclusion. Many times we as pain physicians try in the lifespan of a patient with chronic low back pain to find, if possible, specific pain generators to help the patient in his journey, in his multidisciplinary treatments, and give him further available opportunities to treat specific pain generators that can be at least part as a triggers of their low back pain experience. And in this regard, facet joint syndrome theorized in the first half of the 20th century is a painful low back pain condition that arises from most of the times arthritic changes in the interapophyseal joints, so-called facet joints. And the clinical presentation is mainly the same of the non-specific low back pain with dull pain in the low back that usually does not radiate into a leg. Even if many times we can experience and we can find mixed pain in these patients or what is called the pseudo-radicular pain radiation, that is a referred pain arising from not an involvement or a pinching of a lumbar root, but from the facet joint itself. Usually the patient with facet joint syndrome has no big issues with sleep, excluding the issues given by the chronic pain conditions by itself. Usually, NSAIDs have an effect, but most of the time it is limited, and you will not find in the clinical investigation, in the clinical examination, bladder and bowel function impairments that can instead be brought out by, for example, discogenic pain or cauda symptoms. The patient experiences almost the same limitation that the non-specific low back pain patients experience, like physical and social withdrawal, because physical inactivity, fear avoidance of chronic pain may limit the patient function. And also many times the social aspects linked to work or labor issues that must warrant for those patients the same multidisciplinary evaluation and treatment like the one that should be granted for all the chronic low back pain patients. While you find the clinical signs that may be referred to the specific face and joints as a pain generator, you can search, for example, for the CAMPS test, that is the test in which the provoked unilateral pain is exacerbated by the extension and the rotation of the lower back that may be a sign of a face and joint involvement as a pain generator. You will find usually a negative LASEK test. You will find pain that's worsened by the prone position. Usually the patient tells you that he is no more able to sleep in the prone position. But all those signs, even if they are suggestive of a low back pain arising from a facet joint condition, usually are not extremely specific. So you will anyway have the need to confirm the diagnosis, to perform a diagnostic blocks or interventions if the patient requires. I think that we can also move to our clinical examination video that has been produced by Dr. Emanuele Piraccini from Bologna, and we can see it now, a short clinical video also on the face and joint syndrome clinical examination. Please, Sofia.
Good morning, Mr. Brown. My name is Dr. Emanuele Piraccini, and welcome to our pain clinic. Please tell me which is your pain, where is your pain?
I suffer from pain in my lower back due to a physical effort. It's in the lower back here.
Did it start suddenly or slowly from 2 years ago to
Yeah, it was gradually,
Okay.
but it increased since 2 months. After my job, the only thing that I can do is sit in my chair.
Okay, so once you sit in the chair or once you go to the sleep, the patient disappear or it is reduced, isn't it?
Yes, then I feel no pain.
Okay, so your sleep quality is good.
Yes, when I twist my spine or when I backwards or arching my spine, the pain is increasing.
Fine, so let us go to perform the clinical examination. Please try to move and to bend your back. Okay, does it hurt?
At the end, yes.
Try to extend your spine.
Painful, yes.
Yeah. Try to twist in this way.
Not too far.
Now I'm trying to move your legs just to see if there is a problem in your spinal nerve roots. Please tell me if it hurts or not.
No.
Does it hurt?
No.
Open your... Fine. Does it hurt?
No.
Okay. Does it hurt?
No.
Here, does it hurt? No.
No.
Does it hurt?
No.
I will examine your Your back? Here?
Yes,
Oh,
yes.
sorry. If I touch you more lateral, worse or better if compared to the central part?
It's a little bit better.
And here the sacroiliac joint? Nothing.
Okay.
Oh, it's okay, fine. Here the piriformis muscle?
Okay.
Okay, if I crush in this way,
Okay.
it's good. Here above?
No problem.
No problem. Lateral or here?
No
Nothing.
problem.
So as you see, usually all the tests, the clinical tests that are used for the search of involvement of spinal nerve roots or the clinical tests to examine the hip joint, the sacroiliac joint are negative in the facet joint syndrome. Most like it is for for non-specific low back pain. So for those patients in which we have a clinical examination that may suggest it, we can further have an indication to diagnostic nerve blocks and further interventional treatments if diagnostic nerve blocks give us a positive indication about a possible specific source for those chronic low back pain. So as we have seen and we have also heard from Indra, when it's in your view as a physical medicine specialist, your usual indications or the cases in which you find most helpful to think to suggest a patient a diagnostic nerve block in your clinical routine practice?
Yeah, it's a good question. It depends on history, taking the whole pain picture, pain-related symptoms. It's if pain is very localized, indicating a local abnormality, or it's more spread, indicating very much spread muscle tenderness and generalization of pain syndrome. And in maybe in primary healthcare, it's more easy to find more how to say more patients selected more for diagnostic blocks when they do not have so many other symptoms, when you exclude other possible causes. In physical rehabilitation medicine, we usually doing pain analysis and seeing if there is a part of arthrosis in facet joints, and if we see that it is a very strong pain generator, so we also asking for diagnostic blocks just to see how it works. And it's very much depends on clinics, on the pain, on the functional impairments, that you can understand which pain condition should be treated at the first place.
Yes, usually diagnostic examinations like spinal magnetic resonance or spine CT show you a specific or non-specific signs of interapophyseal joint arthritis that may be more or less localized, and so they gives you informations only if they are put together with the results of your thorough clinical investigations. And moreover, at least for what's our experience, those patients shall at least being evaluated and treated for an adequate period from a physical point of view, because if you are not able to make the patient engage with a good exercise program for the low back pain, those patients will have worse results also from targeted and interventional approaches if they are not able to engage into physical exercise and physical program of activities for their chronic low back pain conditions. And in general, when you have a patient for which you have a suggestion for a specific cause of low back pain, obviously a spine MRI is in any case mandatory, because you have to analyze also other potential sources for the low back pain, for example, disc alterations, or also inflammatory changes, or in the patients with red flags, possible other sources of pain, like secondary low back pain from infections, infectious diseases, or neoplasms, so oncological genesis of low back pain. Once you have excluded them, and once you have positive clinical findings for a specific facet joint pain, you can undergo interventions that are suggested by scientific evidence for facet pain syndrome. And if you, Sophia, can go to the next slide, we have collected slide number 12. Yes, okay. Those are the commonly used interventions for facet pain syndrome. Once you have suspicious involvement of facet joints, the first intervention that is usually suggested is the so-called medial branch block. It's a way to anesthetize a single or multiple facet joints to search for a clinical response from the patient. Those medial branch blocks can give rise to a short-term, or sometimes also to a medium to long-term pain relief, and they are used as a confirmation of a facet joint involvement into the low back pain for that single patient. Those are commonly recognized as the first-line intervention to confirm a clinical suspected involvement of facet pain in low back chronic pain condition. There are other possible diagnostic examination that today are in some studies thought as possible indicators for a facet pain syndrome diagnostic criteria, like, for example, the SPECT, the single photon emission CT, that can show increased metabolic ratio into some of the facet joints, but those are at the moment still under clinical investigation and used in clinical studies, not in the everyday practice. Once you have had a clinical response it will be better to repeated medial branch blocks to diagnose a facet pain syndrome. You can then try to be therapeutic also in the medium to long term with in an intervention that's called medial branch radiofrequency ablation, or other kind of ablations of the facet joints that may be targeted not only to the medial branch nerve, but also to the articular capsule or to the dorsal root ganglion. More invasive interventions like the endoscopic neurotomy of the lumbar medial branch are born in the last year, but are not really much used in the everyday clinical practice. So once you have a clinical suspicion of a facet pain syndrome, those are usually the interventions that in the clinical pathway are suggested. First, a double medial branch block to confirm our diagnosis, and then the denervation that is usually done by radiofrequency or by cryoablation. And so we can move to the next slide to talk about and talk also with you, with all of your questions and your suggestions or your doubts about it for all those green zones, because as we have seen, those patients overlap. Patients with chronic non-specific low back pain may develop pseudoradicular symptoms, may develop new symptoms that may suggest a specific facet joint etiology for their pain, may present with changing symptoms that must every day warrant a multidisciplinary evaluation, a constant re-evaluation and treatment. They do respond differently during time to different physical treatments. And so as our point of view as pain physicians, we do know that the patients may be took in charge, evaluated over time, and anytime that we evaluate them, we can have the broadest knowledge possible about chronic pain patients, chronic pain overlapping syndromes, chronic pain comorbidities to evaluate all those aspects regarding physical function, regarding possible new specific causes of their low back pain to provide them the best treatment possible. And in this regard, Indra, I would like to ask you, are there specific physical interventions that we may suggest a patient after he has undergone, for example, an intervention procedure? Are physical interventions suggested to regain the physical function, for example, after a medial branch neurotomy that we may suggest steadily to our patients?
Yeah, I think that restoration of physical functioning activities is the main criterion if we are going to evaluate the treatment. So if not, of course, it's very good if patient is pain-free and does not have pain and feel good, but I think it's most important thing, the restoration of function. So I mean, you need to pursue exercises, and in that case, maybe it's good to have a collaboration with a physiotherapist who can recommend the best exercises for this patient, this particular patient, in regard of, for example, possible other comorbidities, if there is some heart diseases or other diseases, which it's quite usual that our pain patients have even other comorbidities, especially when they're getting older, as well as psychotherapy or psychological interventions if they are needed. So the evaluation of the impairments, functional impairments, and what is important for every patient to continue to restore the function activity is very important. For example, if we will have a depressed patient because of some issues, and patient become pain-free, maybe this patient still will have problems with daily life activities due to other psychiatric issues, so that is important to see and to understand when evaluating our treatment, and if it is not giving the results we expect.
Thank you very much, Indra. So we thought that we would like to leave our last 20 minutes for your questions and answers. So feel free, everyone, to jump in.
Daniela, I can start with one question.
Yeah.
We usually have patients with multiple arthrosis in the lumbar spine, and it's difficult to approach this pain. What are you saying if there are several facet joints involved, and what are you doing in that case as interventional pain specialist?
Yeah. Theoretically, to treat more than one facet joint is not a big issue once you have diagnosed it, because once you perform a diagnostic medial branch block, you can do it easily and with a little more time and effort for the patient, also on multiple facet joints. There is not obviously a clear and absolute way to understand which spinal segment is involved. As I mentioned before, there are some studies and some authors that suggest to use not only diagnostic medial branch blocks, but also the functional radiologic imaging from SPECT, so for single emission photon CT, to understand, especially in patients with inflammatory diseases, if they have an active multiple joint involvement in the spine that can be selectively treated. You can treat up to 3 to 6 facet joints during an usual medial branch block or during a radiofrequency ablation. So you can do it effectively, even if you suspect that there are more than multiple joints involved. But at least for the real world practice, once a patient has a really widespread involvement of lumbar arthritis, most of the times the problem cannot arise only from the facet joints. So they will also have a spinal instability at multiple segments. They will have also a degenerative disc disease that may by itself be a cause of discogenic pain. So they have obviously increased risks of being patients in which their pain belongs in a certain way, in a certain part to the facet joints, but they will most of the times have not a complete result from facet joint ablation. They have pain that arises from multiple sites, so they should mandatorily continue with a general multidisciplinary program for their chronic pain to go on with their treatment.
Okay, thank you. And now we have some maybe questions to ask in the chat.
Yes, we have already a couple of questions. I think I will start with the first one. So if there is no radiological finding of facet arthropathy, but patient seems symptomatic with this, is it the best practice to trial diagnostic injections?
Good question. The clinical diagnosis of facet joint syndrome is clinical. So if you have clinical symptoms that may suggest it, you can try to perform a diagnostic medial branch block. It is really difficult to find almost at all no radiological findings. But if you have a positive response from 2 diagnostic medial branch block, you can think about performing further treatments for that patient. You must take into account all the conditions that are linked for that pain, especially if you face, like it is usually is when you find no clear radiological signs of spinal arthritis, younger patients. So younger patients that experience chronic painful conditions can receive spinal intervention, but must always be evaluated for all the other comorbidities, like reduction of function, like work-related issues, like with psychosocial issues, because most of the time you will find no radiological findings, but you will find other biopsychosocial comorbidities that reinforce the chronic low back pain. Do you agree with me, Indre?
Yeah, absolutely. You're right. Absolutely. Yes. So we have a next question. Please, can you read, Shreya?
I will read it out loud, Daniel. So, does medial branch denervation in facet pain cause atrophy of the multifidus muscles of the spine at that level, and consequently slightly weaken the spine?
It can. It can do. This is why you should be extremely parsimonious with those treatments. You have to evaluate if you want to do them because you have a real benefit for the patient, because there are many different studies that show fatty degeneration of the multifidus muscles after a lumbar facet joint denervation. So that can be a complication. Once you have a patient that needs them, you can choose between thermal denervation or a pulsed radiofrequency denervation. If you have, for example, a younger patient, you may choose a pulsed radiofrequency to avoid the risk of multifidal muscles degeneration if you think that it could be an issue in the medium to long term.
Thank you. So there are studies that find no association between any specific radiological finding and the presence of low back pain or response to intervention. Modic changes may have some possible association in these studies. These seem to differ with your message.
Yeah, modic changes is something it's discussed during last years, and we can have this indication if MRI, but it's we don't look at that as the first primary cause, at least in rehabilitation practice. What do you think about it, Daniela, about modic changes?
Modic changes are mainly linked to the active phases of the discal degenerative disc disease. So it is a change that is preamble to the subsequent segmental spinal arthritis and facet joint involvement. Usually, facet joint involvement in spinal arthritis arises when a segmental instability can rise from a degenerative disc disease. So if you have a modic 1 or a modic 2 change into a segment, you have most probably not a real facet joint syndrome, but the so-called discogenic pain that is not really susceptible to interventions on the facet joints, but can be at least theoretically be susceptible, for example, for other interventions that target the basivertebral nerve. So modic changes can be are associated with episodes or chronic low back pain conditions, but the lumbar spine is an extremely complex structure where you can have a lot of pain generators, and the clinic by itself, it's some of the time just not enough to understand the specific source for the pain, and you have to mix clinical findings, imaging findings, diagnostic blocks if you have the possibility to perform them, and then to put together those drawings, you can offer the patient some treatments, but generally speaking, you will be able to treat some of them specifically for also sometime for a medium to long term, but you shall not forget all the contour for those patients.
Yeah, and for modic changes, treatment, I mean, staying active and doing exercises is one of the treatment recommendations because despite the pain, patient needs go on with physical activities to strengthen the muscles. For example, in our pain clinic, it's not unusual that many patients with low back pain, especially when we have degenerative disc disease or other issues, were sent to the orthopedician just to overweight if there is some indication for even surgery, disc surgery. So I think this is a little bit bigger issue, and as we mentioned, that spinal cord is lumbar vertebra is very complicated with all joints and nerves involved. So we have to have a complete picture of this. Yeah, should we take if we're satisfied, because I mean this could be another webinar to discuss molding changes and degenerative disc disease
Yeah.
and indication for operation and the syndromes after operation and when patients should be operated in concern of other pain conditions and alterations in the pain system. But maybe we can leave that. Today's seminar is more,
Yeah.
more specific. So can we have the next question, please?
Yes, we have a last one. So there is a possibility that a patient may have overlap with non-specific back pain, hyperalgesia, and muscle tension, like the patient in the non-specific clinical pain vignette, but also some sort of underlying facet joint disease, which may be masked due to more general back symptoms. So how can you exclude facet joint disease in those patients, especially that it may be a block for them, helps flare down the rest of the symptoms?
Yeah, thank you. It's very clinical question that we see in clinics, and it's always discussion, which is the first which comes to generate the pain. So the videos and our presentation is very pure conditions, and in clinics we have this mixture which you already described. So maybe Daniela, if it's more question on intervention for this such mix, which is mixed pain condition that we see.
Yeah, it is.
Yeah, how do you, as interventionalists, are thinking about it?
That, as we said different times, also today, our patients oftenly overlap. And obviously, you can have a facet joint component also in a patient that had an unspecific chronic low back pain conditions. This is the reason why pain medicine itself has a meaning to be able to follow up patients, to be able to evaluate them for all the possible comorbidities and the evolutions of their pain pictures, and to be able to address them to the better evaluation and treatment possible. So you can obviously find a patient in which low back pain begins as a acute and then chronic facet joint pain condition, but you can also find the contrary, the patient with an unspecific low back pain that over time develops specific chronic facet symptoms. So you will need to be able to evaluate those patients, knowing what the problem may arise, and you, like in all the other cases of chronic low back pain, can perform on those patients at a certain point during their life course, a medial branch block, and then if needed a radiofrequency. This is the standard pathway that doesn't change if facet joint pain arises before or after during the clinical course.
And also, I think it's I found it more easy to diagnose non-specific low back pain in younger people, because we do not have so much disc degeneration and arthrosis changes in the spine column. So when you have older patients, it's usually you have background of these changes, and you have to understand the origin of the pain by doing the clinical investigation. As you mentioned, at many studies, MRI studies, we show that there is no clear correlation between radiological findings and clinical findings, and maybe radiological findings are saying one thing and you find completely another thing, and which maybe is more important than radiological changes. So always just concentrate first on your clinical investigation, and then maybe you can look at the MRI studies just to see how much does it correlate, and is it a meaning to go with a diagnostics blocks, which indeed we sent our patients, even young patients, for these blocks, but in that case we find very clinical indication. What do you think, Daniel, about it?
Yeah, I do completely agree with you. The same clinical picture does belong to a patient that may have a completely different age, comorbidities, necessities in the psychosocial aspects of life, work issues. So you cannot give the same answer to two different patients that have exactly the same clinical condition, because you have to evaluate them globally for the different aspects for which one intervention may be more meaningful for one patient and probably less meaningful for the other. So you have to know the complete picture before giving an answer, apart from the clinical findings and apart from the radiological findings.
Thank you so much. And I think it is our final words. So thank you so much, Inge, and thank you, Daniele, that you were with us today and you did this wonderful discussion on this topic. You can find the webinar online on our YouTube channel, so please follow us, the EFIC YouTube channel. And you can find the clinical case videos, so you can access them in the EFIC Academy membership, and you can find the full videos on non-specific low back pain and lumbar facet joint syndrome as well. Thanks for the questions, and thanks for the wonderful answers. Thank you so much being here, and see you next time in the next webinar. Goodbye.
Goodbye. Thank you for your attention and your time.
Bye bye. Thank you all for the attention.